Dr. Steve Chang, he graduated from the University of Western Ontario, Schulich School of Medicine and Dentistry in 2007. After practicing general dentistry in the GTA for several years, he obtained his first master's degree in craniofacial pain from Tufts University in Boston. Apparently, one master's degree wasn't enough, so he went on and obtained his second master's degree in implantology from Goethe University in Frankfurt, Germany. Again, knowing Steve, this wasn't enough for him. He's always on the pursuit of excellence. So he continues to pursue his passion for dentistry as he begins his graduate specialty program in prosthodontics at the University of Toronto this coming September. So it's my honor and my pleasure to introduce my friend, Dr. Steve Chang.
Thanks, Jake. I really appreciate that. Let me start sharing my screen here and we'll get started. Hope everyone is doing well. There's the entire lecture right there. Perfect. Okay, can everyone see the screen okay?
Yeah, we can see you clearly.
Awesome, okay. Well, I'd like to start by thanking Jake for that warm introduction and all the folks at Dentistry Academy for putting this all together. It's absolutely amazing what you guys have done and trying to help the next generation of dentists. Very proud to call you friends and be associated to some degree with this. And a special shout out to Dr. Shergan for putting this all together. Bro, you are such a giving human being, and it's a pleasure to be in your acquaintance for sure. So thank you so much. This lecture, specifically for the new grads out there, you know, it's I'm sure it's tough to kind of graduate into this environment, but I assure you one thing, that every graduating class has probably said that times are different now than they were 10 years ago or 20 years ago in dentistry, when those dentists started. I remember my boss telling me that when he graduated, he just put a sign on the door saying, "I'm a dentist," and he started practicing. And, you know, for us, when I graduated in 2007, that's me in the picture there right behind Dr. Sandhu, with that goofy smile on my face. You know, times were different then, and times are different now. The only sure thing in dentistry is that it's constantly changing and constantly evolving. So I encourage you guys to keep pursuing this profession in all its capacity. It's a wonderful profession that you guys have joined, and I welcome you all and wish you all the best in this dental journey. So I'll tell you a little bit about my story. Jake, thank you for that introduction. Yeah, so, you know, I've done a fair amount of education, but I think it's not so unique to me. I think dentistry, I think you can see with the lineup of speakers, I mean, they just have a passion for dentistry. It's kind of weird, this profession, how we seek out education to better our knowledge base and our skill set. And I do think it is very unique to dentistry. So I think the key is to continually learn, and there's so much education out there. Dental school is just a start for you guys. So the world is yours there. The world is your oyster. Okay, so today we're going to talk about treatment planning. Excuse me, let me just change up my screen here a little bit. Let's see my screen a bit better. Okay. In particular, we're going to talk about treatment planning, the All-on-X, okay? Implant-supported restorations of the edentulous arch. And now, I do have to apologize that, this lecture was kind of pushed together. I had, as Dr. Shergan said, I had to pivot on Friday after listening to that, the lecturer there who did an amazing presentation, but happened to be about 60% of what I was going to talk about. So I had to put this together over the weekend and put some past lectures together. And I can appreciate that All-on-X is not necessarily a topic that is, that should be first on your list of education coming out of dental school. But I think treatment planning is always a skill set that we should be learning, from the new grad to the most experienced dentist, okay? Things are constantly changing, and so the way we treatment plan is the crux of our profession. So to start, we really have to understand, what type of dentistry we're going to be doing, okay, to properly treatment plan. And to this day, I'm not sure I fully understand what evidence-based dentistry is, but I think I have a better idea now, okay? And for the new grads out there, this is a challenge to practice evidence-based dentistry. It really is. What does it even mean? By definition, right, it's integrating dentist experience with the best scientific data and meeting the patient's need. But that's not a specific goal, okay? It's a range of goals. It's an overlap of goals, right? So you can appreciate that, from a new grad perspective, your dental expertise is not as somebody who's been practicing for 20, 30 years. That's okay, right? I know people who never read scientific literature at all, okay? That might not be so okay, but at least getting some concepts that are proven evidence-based, okay, from whether you're talking about Pankey or Dawson, Coyce, whatever, getting a foundation for your science, right? And then, of course, meeting the patient's needs. Not everyone's always so good at understanding what the patient wants or needs and matching that preference together. So it's a loose target, okay? It's a range of targets. So to better appreciate evidence-based dentistry, I'm going to kind of change it up a little bit. We're going to talk about poker. For me, doing dentistry is a lot like playing poker. Okay, now hear me out. Okay, and not for 1 second am I trying to trivialize treatment planning or trivialize the patient's needs. Not at all. But what we're talking about is game theory. Okay, so I like playing poker. Okay, game theory is trying to understand. It's the study of mathematical models. Okay, to better understand the interactions between two individuals, two rational decision makers, okay? It's a way we study behavior between human-to-human interactions, okay? And you have to understand with game theory, it's understanding that there is a ever-changing environment. Every patient that walks through your door is not going to be the same. The clinical situation, their personality, their financial goals, okay? So to understand treatment planning, we really have to understand what game theory is and how does that apply. So let me use poker as an example, okay? So in the past, poker was kind of played like, it's just who has the best odds, right? I have a pair of aces, I win, versus someone who has 2-7, okay? But the true poker players, they understand game theory. And they develop a system called game theory optimization, okay? And it basically refers to understanding a range, probabilities. So they have a better understanding of how these cards are going to play out, okay, without ever seeing the opponent's cards. Probabilities, a range, okay? They also talk about exploitative play, which is attacking the opponent's weaknesses, okay? And you'll see in a moment why this applies to treatment planning. This is a range of this is the entire deck. These are the options that you get when you're playing poker, okay? Anywhere from a pair of aces to a pair of twos, okay? Suited, off-suited. What they've done is they've now taken cards and based on where you are in your dealing next to the dealer, they're starting to average out. So they're starting to gain data about how people behave, okay? So they are better, they have more predictive value on how to play poker than the average individual. Everyone know who this is? This is Daniel Negreanu. He's a Canadian poker player, right? Very well known. And what he talks about is for the true masters of poker, they talk about strategy, okay? It's not just luck. It's about strategy. And they do both of these strategies, okay? Game theory optimized and exploitative strategies. So what does that mean for dentistry, okay? I know it might seem like a bit of a stretch, but hear me out. Early on in my career, I met this gentleman. I think most everyone in this chat room knows who this guy is. The early guys probably not, but you will. Okay, this is Dr. John Heiss. Okay, in my opinion, probably the best dentist on the planet. He really sets the lens in which I view dentistry through. Okay, so what does he talk about? He talks about core values. Okay, and what core values are is really optimizing, right? It's game theory optimization. What he means is have your core values, have a strategy, right? But then he says, have an acceptable compromise. And what does that mean, right? Oftentimes when I meet new graduates, X plus Y equals Z. It means the patient walks in with a broken tooth, that person has to have a crown, and there is no in between. I think the goal of today is to understand that there is a range of acceptable treatment, but it's getting as much evidence as possible and laying out a game plan, game theory optimized, okay? Because we don't want to do treatment planning just on treatment options, right? It's a decision process. How do we get from point A to point Z, right? With the patient in mind, practicing evidence-based dentistry. And if I have to sum it up into one phrase, it's about prognostic value, right? It's not about black and white treatment planning. And the more complex you get, the more complex the treatment, the more important this type of strategy becomes, right? If it's a single tooth with caries, okay, either you do the caries, you don't do the caries, right? Very little in between. But when you're talking about a full mouth rehabilitation, whether it's implants or teeth, maybe, or 8 veneers, whatever you're talking about, it is exponentially more complicated and more layered. So that's why game theory, having a strategy, is so important. So what's the game theory for dentists? Well, it's diagnostics, right? This is the core values that we have. Now, coming out of dentist school, I'll tell you, I didn't have a full understanding of what the core values are. I mean, I understand to some degree what gum disease is when I come out of dental school. I understand I have to fill a tooth with a cavity, okay? But the way dental school puts it together is not quite complete, okay? Now, I'm not trying to say anything bad about dental school. They have its limitations. I understand that, okay? This is just the starting point for the new grads, right? And there's much to learn from there. And there's nothing to be ashamed about that. We all started somewhere. Right? So when I met Dr. Heiss, we pay him a lot of money and get to see his course. I highly recommend it. He brought up the diagnostic opinion. This is the game theory for him. Okay, it's consensus-based. It's evidence-based. It's systematic. Okay, but the real value here is it sets a risk value. And from there, we make a prognostic value. That's that game theory part, okay? And remember, guys, there is no treatment without proper diagnosis, okay? This is the key. So look at the core values, okay? Now, one thing becomes very clear, especially for general dentists, I feel, okay? We as general dentists, we kind of go everywhere, right? We're doing endo, we're doing pedo, we're doing ortho, we're touching a lot of different specialties in this little region of the mouth, okay? So it becomes very complex. The complexity increases the more we start to branch out into dentistry, doesn't it, right? And I think what's happening is that the amount of complexity of knowledge is exceeding our individual capacity to remember, to put things together, right? Especially the more complex the cases get. The full mouth rehabs, the all on 4s, all on X, okay? And you will have these patients in your office. Okay? Now, I'm not suggesting, you have to go out and do a full mouth rehab on day 2 of your career, okay? But the better you can treat and plan and diagnose, right, the better off you and your patients are, okay? One example that I'll briefly touch on about the complexity is the Boeing 299 bomber, okay? Now, for anyone, check out this book. It's called the Checklist Manifesto. I highly recommend it, okay? In this book, they talk about the Boeing 299 bomber. That's the Boeing 299 bomber. It was supposed to be a game-changing plane for Boeing and the United States for World War II. It had 4 750 horsepower engines, a max speed of 236 miles per hour. This was supposed to change World War II, okay? It was significantly more technologically advanced. But at the same time, it was significantly more technologically advanced, which made it significantly more complicated to fly. During its testing, while it was trying to win a contract with the US military, it crashed, killing all its crew. Now, why? Well, they forgot to disengage what's called the gust lock. That's the gust lock. Back in the day, this was all done manually, okay? They knew where it was. They knew why they had to release it. They knew how to do it. They knew everything about it, okay? They just simply forgot, okay? And both the pilots died. So why is that important? Well, since then, they made it mandatory to have a checklist, okay? Such a simple thing. But it goes back to what are the core values, right? Are you game theory optimized? Okay. So then put that in context between pilots and dentists. When I graduated dental school, I went in there with no plan. I just did my best, okay? And I don't mean charting. Charting is different, okay? Charting is not a plan. That's just part of the data, okay? But I didn't have a plan. And I'm gonna recommend you change that now. So the checklist. What do we have? Okay, so that's the checklist I use. Now, lots of different methods of diagnosing, lots of different occlusal concepts and these different camps. Doesn't matter, but have something, have a plan. And this is the one that I use for every patient, okay? Every patient. Doesn't matter what type of treatment I'm doing, okay? And this is developed at the Koi Center, okay? I don't want to get bogged down by the little individual points, okay? I will go through a case here, but I don't want you guys to get too bogged down on that, but just the overall concepts, okay? So obviously, we're talking about perio, we're talking about teeth, the biomechanical, we're talking about function, how the teeth interact, okay? And then we're talking about dental facial, and understanding that they're all intertwined. In the context of this talk, we're going to talk about this one patient, okay? And we'll call him Howell. Hisham, you know this case, okay? So Hisham and I, we did this case together. Okay, so nice guy, but clearly he's got some breakdown of his dentition, right? And he needs to have some restorative work done here, okay? So I will go over the pictures in a bit more detail. That's it. Previous slide was without his partial, okay? And with his partial. Now, one of the key parts to proper treatment planning, you have to have the right records, okay? This is an absolute must to get into All on X, okay? If you can't even take these photographs, you can't do All on X. Simple as that, okay? You have to have the proper tools at your disposal to make the proper diagnosis, okay? We also have a CBCT, which you'll see a little bit later. Here's the panorex. You can see the breakdown of his teeth. Okay, he's got all his maxillary teeth have endo and the bridge, and that bridge is loose. It's come out, and you'll see how we break this down. Okay, so let's get into it. So if you have this case, this patient walks in your door. Okay, you need that strategy, game theory optimized, right? So we're going to start it again with the checklist, periodontal. Okay. And that phrase, prognostic value, that's what we want, okay? He's got gingivitis. I mean, clearly he doesn't really brush that well. There is gingivitis here. He's got attachment loss. I can see the uneven margins even with his restorations, okay? And again, don't get too bogged down with the specific details here, right? He's got that posterior abutment is loose, right? It's got bone loss, right? There's recession. I believe there's a posterior bite collapse because that bridge is kind of rocking, okay? I think this is pretty high risk. So what does that mean to you? What does that mean to the clinician? Well, we're going to look at this particular situation with the periodontal condition in mind, okay? And we're not going to make a final treatment plan right now because we don't have enough information yet, right? But I can say that the prognostic value here is that this person's periodontal condition is quite poor. Okay, keep that in the back of your mind. Why does it matter? Because at the end of the day, we want to give this guy teeth, right? Something. And we have to worry about how our prosthetics are going to affect the periodontal condition. We got to worry about emergence, cleansability of the prosthetic, right? Now, the prosthetic on the left is all wrong, but just for argument's sake, let's just say this is a conometric type of restoration, right? Do we need a flange? Do we not need a flange? Okay. These are things that we need to consider. How about this case? Not one of mine, but let's say that we have a case that is where the implants are quite palatal in location, but the aesthetics bear the teeth to be out more buccally. How is the patient going to clean this? Okay, not impossible, but what's the risk factor for a perio patient, and does that matter? This is more cleansable, isn't it? Right. This is even more cleansable, straight to fixture. Certainly that would be more ideal. But maybe, just maybe, you don't want to fix restoration at all. This is one of my cases. This is a conus case where I can remove the restoration. Or maybe even better, maybe it's a locator case, maybe a bit more cost efficient. Okay. But the reality is when you understand risk and get prognostic value, okay, you start to see more things come into your treatment planning, okay, the better your prognostic value. And if you look at this study, the systematic review shows that the diagnosis and history of periodontitis was associated with the occurrence of periimplantitis. Okay, so risk factors. So let's talk about biomechanical now, right? So this patient has a pretty high risk for perio. What's his teeth looking like? Well, I think it's pretty clear, right? Caries everywhere, even that bridge, right? Defective restorations, absolutely. Okay, structural compromises. Am I going to restore those roots? No. They got endo, there's decay, it's impossible, okay? Is it worth saving those remaining teeth, right? Now we're going to go back to the perio a little bit. Right, missing teeth. So what's the risk? I'd say it's pretty high. So if I deem that it's high biomechanically, am I putting a lot of stock into those teeth? Maybe, maybe not. Okay, but we're going to delve a little bit deeper. Now, when it comes to implants, now there's another layer, right? Now we have to think about what's the prognostic value for our upcoming treatment? If we deem that these teeth are all coming out, which just as a heads up, we do, okay, how are we going to start to rehabilitate this patient? What's the risk factor then? What's the risk factor as his current condition? What's the risk factor in their proposed new condition? Okay. Are we going to start to look at an all-on-4 on multi-units? How are we going to design this? Where are we going to place those implants? How much restorative space do we have? What type of material are we going to use? How many implants, right? And these are all questions that are kind of going through my mind at this point, but I haven't completed that picture yet, right? Maybe it's better that we put the implants in, right? Still going to angle, probably avoid the sinus. You know, maybe the patient says, I don't want to be in the sinus. I don't want to do any sinus work. Fine. But what does that look like? Or can we go straight to fixture if we do it that way? You know, this is going to have draw problems, right? Maybe better to straighten up. Okay, so implant planning here is way, way low on the list right now because we haven't even got to all the diagnostics yet. Okay. We have to look at restorative space. We have to look at biologic width. Okay. For those that don't know what this slide is, okay, this is a surgical guide for alveoplasty to create space, the proposed space for my restoration. And we got to account for the biologic width, the prosthetic space, the smile, the aesthetics, and all that. So we'll get to that pretty quickly, I might add. So I apologize for condensing this into under an hour. Okay. So what's the prognosis of the biomechanical? I'm thinking pretty hopeless at this point. There's caries on that bridge, there's caries on the remaining roots. These teeth are coming out. Now, this is a relatively easy decision. But for some cases, it's not so easy, right? You're gonna hum and haw about, you know, do I wanna save these teeth? Do I wanna take them out? So when you have a context like this, a strategy, it makes that decision easier because you're getting some prognostic value. Okay. So now that we talked about the gums, we've talked about the teeth, we talked about functional aspect, right? How do these all things work together? Okay. Very, very important part. You can see with the denture work and the prosthetics worn down. Okay. Now that part of that could be functional, right? Maybe he has a true, you know, bruxing pattern. His chewing envelope is quite wide. Could be a lot of things. Could also be the material that's been used. I mean, they're denture teeth after all. You know, what's his dental history? How long has he had this denture for? Okay. So what we're trying to do is we're trying to build a story, right? But I can't deny that there is some wear on these prosthetics. And how does that apply to my future prosthetic? And you'll see where that comes into play. Right? I also mentioned that that bridge that was there was loose at the back, okay? Thankfully, no TMD, okay? He doesn't say that he bruxes, so that's good. But I can tell you there's a vertical dimension problem here. And you can see that with the photos, right? And in terms of his function, he's wearing down his teeth. So for me, there's a frictional chewing pattern, right? How is that going to change the way we design our restoration, our future restoration? What type of materials are we going to use? Okay. So we're building that story, right? So moderate risk, I think it's got a pretty fair prognosis here. Now, keep in mind when it comes to functional, I know this is maybe getting a little bit too much, but I'll just touch on these points, right? Understand that the functional concept is about what Dr. John Heiss calls the 3 Ps, right? When you're doing big rehabilitations like this, okay, the first thing you're going to look at is the joint. Where do we want to restore it to? Okay. For those that are doing, full mouth rehabilitations, complex cases, right, we're going to change this position sometime, okay? For the new grads, you may want to avoid these patients, the ones where you have to change until you're comfortable dealing with that. Because I think you guys can appreciate that we can't get the teeth where we want them to be until we get the joint where we want it to be. Now, the good news is this, is most people walk in your door and their P1 position is ideal, okay? And it's a range, okay? So we talk about the joints, where we put the teeth within that joint position, and then how are we gonna organize the teeth, and that's the pathway, okay? And the way, one of my mentors early on talked about the cow, okay? He said patients are either cows or rats. I didn't understand that at first, but I get it. Because these are cow's teeth. And the rats, these are rats' teeth. They have a very different appearance because rats only chew up and down. Cows chew like this, okay, based on their diet, okay? Now, which one is Howl? Howl's a cow, right? So we got to appreciate that. And remember in the back of your mind, what is function, right? It's a complicated topic, but I'll break it down to this. It's a force management system. 100%, it's about force management. It's not about aesthetics, okay? Force management. Why? Let's look at the evidence. Muscles and mastication, what does it do? It pulls, right? We have tooth wear. Now, what would happen if we didn't have tooth wear? What happened if our enamel didn't wear like it does? Teeth would break, right? And what do we do as dentists? We put restorative materials in there with different wear rates, right? We have PDLs. We can move teeth. Bone density. Our bone reacts. That's how implants work, right? Tooth movement. Teeth need to move when they're erupting, when they're, we have the ability to move teeth for the maxilla and mandible to meet, right? Condylar remodeling. When you look at pans, take a look at the condyles. If you start to see them beaking, right? Why are they remodeling? The human body is amazing. It's highly adaptable. Discs remodel as well. There are studies that show that the temporomandibular joint disc can pancake, can change shapes, can even fold on top of each other. Okay, the ends can fold together in rare cases. Okay, and even rarer, even the glenoid fossa can remodel. So it's a force-bearing system. But now let's throw implants in there. Now we have more things to consider, don't we? Right? We have restorative fatigue, porcelain fracture, right? Denture tooth fracture. We have cement fatigue. We have screw loosening. Implant abutment connections can fail. Implant bone connections can fail. So now this force management system is now more complicated. So we have to look at the functional aspects of dentistry. And keep in mind, all of this should be seen in 3 dimensions, okay? Unfortunately, a lot of the times our data is 2-dimensional, but we're now moving into the 3-dimensional world, okay? Tooth position, condylar movements, all these 3-dimensional assessments. And at this point, the reason I show this slide is now we can start to go back. I look at treatment planning like a snail eating its tail. Now that we work through perio, biomechanical, functional, it's okay to go back and keep on circling back until you fine-tune your treatment plan and your diagnosis, okay? So now we look at dentofacial, right? How does all of that we've discussed affect dentofacial? How does it look in the mouth? Now, for me, this is the least important thing. But for the patient, it's the most important thing, often, okay? So that makes it important for you. So let's look at the color. For Howell, it's not so bad. He doesn't mind the color. Simple question. You like that color? Okay, let's try to match it relatively close. Now we're dentulating his maxilla anyway. We match his lower denture. okay? But not every case is that simple. We start to develop his maxillary edge position, right? We're going to modify his posterior occlusal plane. Why? This will become a little bit more clear later on. I don't want to get too caught up with this, but the lower denture is lacking a little bit of restorative space. So now I've got my red flags up from a biomechanical standpoint. So now we have to change that. And how is that now from a biomechanical standpoint? How does that change our dentofacial standpoint, right? Then we develop the mandibular edge. Well, the mandibular edge is set, so that makes my life easy. But again, not every case is like this. Mandibular posterior plane will match the mandibular maxillary posterior plane, right? So we're getting them to meet. So if we're going to change something, we have to figure out why and how. Are we going to change the tooth position? Are we going to change the P1 position, the joint position? Okay. You can see how it's now the snake eating its tail. We're going to go back to the functional part. And how are we going to design the teeth, right? So these are all things that are very important when developing a larger case, right? For the smaller cases, this becomes very easy. No, patient's not interested in doing 8 veneers, fine. But get accustomed to doing this for every patient. Develop your plan, your strategy, right? Game theory optimized. Okay. Lip dynamics. Now, this is an important one for an all-on-4, right? Why? Because if the patient smiles up to here, you know, I can't have that transition zone showing. So maybe we're not talking about a fixed restoration. Maybe we're talking about a removable restoration, right? So we can have a flange. Now, a lot of my patients, they seem to come in with this preconceived notion that fixed is better. I don't believe that for a second, okay? Fixed is an option amongst other options for full arch implant dentistry, okay? So it's understanding that there's nuance to this. We have to put all the pieces together to fully meet our patient's needs, right? You know, for Howell though, pretty low. So I'm already pretty happy now, okay? It's acceptable. Pretty symmetrical, okay? Scallop form, okay? So scallop form in terms of his gingiva, pretty flat, right? He's got these old restorations, he's had recession. He's gonna have a flat architecture. Now, why does that matter? Well, let's say you have a patient who has a really high aesthetic demand, but already walks in your door with a flat scallop form, okay? Are you gonna do an FP1 restoration? Maybe not, right? So these are all things that you have to consider and circle back to the previous diagnostic tools. Okay, not going to talk about the mandible too much, just for time's sake. I better hurry up here. Okay, okay, good. So the prognosis here, now this is an important part, okay? The patient visions. I wish this actually probably the first thing that should pop up, okay? Patient has reasonable demands, okay? I'll tell you right now, automatically, if everything is perfect, but the patient's vision is highly demanding, it's a high risk factor at hello. Okay? Keep that in mind. Now, when it comes to all on X, we have now different challenges, right? What happens to the edentulous patient? Well, their bone starts to, when the maxilla starts to move up and in, right? So how does that affect Howell? Well, he's got roots, he's got teeth, so that helps us out. But not every patient is like that. And if this is our proposed facial design, what happens if the patient's bone loss is too deep? Are we going to put implants there and have a restoration that bulky? Sometimes. Sometimes we have to look at the face. Where does this denture fit in the face? Okay, right? Edentulous people oftentimes have a facial collapse. Okay, they have a vertical collapse. Does that matter? For some patients, absolutely. Okay. Now, if this is a scenario and the denture wants to be right here and the bone is right underneath it, fantastic. I can get the implants relative to the teeth pretty accurately. But what happens if the ideal plan is here? Okay. You can see from this picture, right, that the picture on the left, probably ideal, right? This denture would probably push that lip out in that position. Okay, we get some facial support. But then we're also going to have to open up vertical, right, to create that space at times. So let's look at Howell. And again, this is where that patient that says, you know what, I just want teeth to function, right? Those are the patients you want to start off with, okay? And he's a pretty easygoing guy in that sense. Financially, not so easygoing. And that also factors in, right? Remember evidence-based dentistry, patient's vision. Okay, but from an aesthetic dental facial standpoint, pretty good prognosis. Okay. And as you get more involved, the more complex cases, okay, highly recommend that you learn how to communicate this with your lab. Okay, your lab is so important. Okay, now let's put this together. I think I have 10, 15 minutes, so I apologize. I'm probably going to rush through this pretty quickly. Now, we started with the perio, biomechanical, functional, dentofacial, okay? But when we're putting it together, we start with the end in mind. But don't be afraid to circle back to revise, okay? Very important part, in all on X anyway, is to have a simulation. Now, simulation is not just for you, it's for the patient, right? This is a very powerful, okay? And it's very easily done, okay? Then we start to put our data together, okay? This is cone beam, facial photos, okay? You've seen these pictures before. This is where, from a biomechanical standpoint, I have a little bit of a red flag. It's already burning through the teeth. I'm starting to see access screws. So this patient's doing something, okay? There may be an OVD problem here. You can see the wear. Start to make those decisions now, okay? Putting this together. You can see some of the perio that's involved here. But we're starting to stack the data together. And I've got my strategy now. Now we're going to start to build a plan, okay? And we start with the dental facial, okay? We put it in the face, the proposed plan. How does it look? I think it looks pretty good. Again, he's pretty easygoing, so I'm not overly concerned. The risk is pretty low here, okay? But we're going to do facially related tooth positions, intra-arch tooth positions. You know, how big are the teeth? You know, one of the simple questions could be like, how do you like the teeth that you have right now? What do you want to change, right? I mentioned that we're going to change the occlusal plane, but we're not going to change it right now because he's not willing to change his lower denture. Okay, so how does that play out? We look at lip dynamics, lip support. Start with the end in mind. Okay. Then we're going to look at the functional part. Okay. Now, in my mind, I'm thinking, I need more space here from a biomechanical standpoint, but to get to there, I got to put into the functionally right spot. That's that P1. Where's the joint? How can I put my teeth that I want in the joint where the joint needs to be? Now, the good news for Howell is his joint position is pretty good. He's not complaining about pain, no clicking, no popping, nothing, okay? But not every patient is going to walk in your door like that. Imagine Howell walks in and says, "Oh man, I got joint pain." You know, is your first answer going to be, "Well, let's do an all-on-4 for you"? Probably not, right? Because that patient is not going to be happy with this brand new restoration and they're still in pain, or they're breaking restorative materials. You know, what do you do then? Now you're kind of stuck, right? So what we decide to do, okay, I'm not going to get into all the details here. We're opening up his vertical a little bit. I'm cheating here, right? Game theory optimized here, folks. I want space in a functional position that he can handle. This was quite easy for us because he's the right patient. Okay, now there's many different ways to open up OVD, not the point of this talk, but this is how we open it. Okay, we got a bite registration. Now from there, right, we looked at P1, the joint position. We looked at where the teeth are going to go. We looked at now P3, which is the pathway, you know, cow or rat. He's a cow. Lower teeth, cow teeth. So we're going to build cow teeth at the top, right? You know, there's concepts like CR, MIP. I'm going to not get into that too much, but these are joint-related rehabilitation concepts that you will learn, okay? Another day, maybe another talk. We're gonna talk about guidance, okay? When you have a setup like the maxillary denture, that fixed denture, which is not coming out, it's gonna be hard to adjust that. So we're gonna have to match that, okay? Now the question is, we're gonna provisionalize. How are we gonna provisionalize? Especially for people who have joint problems, this is a good opportunity to get them comfortable in some respect, okay? But now we're going to start to look at prosthetic considerations from a functional standpoint. Now we look at the design, okay? This is the biomechanical part now. Now, this is a bit of a messy slide, but the point of this is for those that, you know, do All-in-X, probably saw this pretty quickly, that the posterior region, that distance is quite minimal, okay? So we can measure this out in our treatment planning software, okay? There's not enough for a bar. So we're gonna have to remove some bone here. Now, I know what some people are thinking. Well, why didn't you just do FP1 then? You don't need as much space, okay? But then I went back to the risk factors. He's already breaking stuff down, right? Look at his lower denture that he's not going to change right now. Do I want to put zirconia there? Do I want to put porcelain there? A hard substance against a really weak substance, okay? I'm not sure I had the right answer there, okay? But I was worried about that. And so maybe the denture, you know, the hybrid model may be better. I'm not so sure, okay? We haven't been able to finish this case yet because of the pandemic, but we'll have to make those decisions shortly. Okay. So from a biomechanical standpoint, now we start to develop our plan, our implant planning, okay, based on the face and based on our prosthetic, based on our function, okay. And this is where we put the implants. And I'm not going to get into all the detail, but there are a couple things to note. Of course, we're going to avoid the anatomy. We did talk about straightening up the posterior. Not interested in sinus augmentations. It's fine. Okay, so we're going to avoid that. We're setting the plane. This is all now based on the dental facial. Okay, so that we can optimize our biomechanics of our restoration. Okay, so that the access holes from the multi-unit abutments, the screw channels, are now pretty much situated in the right spot, not coming out the facial, not too palatal, that right balance, okay? So we have to look at now restorative design. Is it fixed versus removable? Are we gonna do what type of restorative material are we gonna use? Like I said, zirconia versus denture teeth versus porcelain, EMAC. These types of things now start to matter based on the functional dental facial, okay? And even to some degree now perio, right? Knowing that zirconia is quite nice to tissue, okay? And our implant position at the very end starts to come into play now, right? And then we start talking about what type of abutments are we going to use, right? Because abutments have different heights, right? Straight to fixture, we get a little bit more restorative space. And we have to use a multi-unit abutment. Now we have to have more space, okay? And all based on our functional determinations, OVD, okay? And then of course, we can't forget about perio. At this point, we've determined that he's got some periodontal risk, okay? We're gonna have a conversation with him about whether you know, it's the right decision to go fixed, right? Evidence-based dentistry, what does a patient want, right? Am I being neglectful by doing fixed? I don't think so. I think the patient has an opportunity. He certainly manages the lower one okay, right? But yeah, I'm going to give him a warning. I'm going to tell him that, look, these are implants. They can fail. Understand that this is the management requirements, okay? So we're also going to make decisions on perio. You know, do they need gum grafting? Do they need, you know, connective tissue grafting to get thickness, right? Maybe their vestibule is too low, okay? And then what about the maintenance? If this patient cannot maintain this restoration, this patient does not get this restoration. Then we're going to look at locators. Remember, guys, these people lose their teeth for a reason. And then how are we going to maintain them in a one interval, okay? And that periodontal condition does have an impact to the prosthetics, doesn't it? Right? It's that snake eating its tail again. Okay. And of course, implants have its own independent factors now, right? Now we have to look at bone density. Because if we're going to do all on 4, all on 6, right? And the plan is to immediately load. We need good bone, and we need the right tools to get primary stability on an implant. It's vital, okay? Because this patient does not walk out of your office with fixed teeth if you don't get primary stability. So are we looking at that ahead of time? Okay. Game theory optimized. Right? Okay, I'll skip this part, right? We need a certain amount of torque and we need a certain amount of ISQ to get stable implants, right? And if you're doing 6 implants, you know, I get this question often, you know, how many implants is the right amount of implants? Well, that depends. There's so many factors to that question, right? But what I can tell you is that if the patient has very, very soft bone, and you can kind of make an estimation on the CBCT, then you may want to bite the bullet and put in more, okay? So let's finalize this case, how we did it, right? It's not perfect, I can admit that. But I hope you can appreciate how we kind of, not just myself, but Dr. Shergan and the lab technician, how we put this together, okay? So there was the bone reduction, pre-planned bone reduction to there, okay? Teeth were extracted. These are the surgical guides, okay? Pre-planned implant position based on what? The prosthetics, which is based on the dental facial design, okay? The MUAs we decided, okay? Because we want to avoid the sinuses there. And there are the 6 implants, okay? There's the final restoration, right? And your implant position is important because it minimizes the risk on your prosthetic. The patients want a thinner profile, for sure, okay? I'm pretty sure the final can be even thinner than this. But if your implants are, you know, out this way, then the lab's gonna have a much harder time fitting the materials into the dimensions of your implants. So very important to plan carefully there, okay? Pre-planned dental facial designed, okay, I think it looks pretty good. And that was a simulation. This is the final, okay? This is day of surgery. I probably could have wiped his teeth a little bit better. Still got blood there, okay? Christina, if you're watching, thank you very much. You're one of the best assistants I've ever worked with in a short period of time, but thank you. And this is actually Howell sent us a picture a few months after. All of a sudden, he's got new teeth and he wants to now skydive. I don't know. So I'll leave you with this quote. If there was no luck involved, I would win every time. This is Phil Hellmuth, another poker player. And the reason I put this slide up, I want you guys to look at it this way, is that with treatment planning, you just want all your cards in your favor. Okay, and that includes proper diagnostics, right? Having a strategy to put all this information together, okay, and have a plan on how to execute that, okay? And then if luck comes along and breaks that, well, that happens too, okay? But the more prepared you are, the better your outcomes will be. Thank you very much. I appreciate your attention. And look at that, it's 12 o'clock. I'm amazed.